So next speaker is Dr. Divya Balakrishnan. Divya needs no introduction, and she is the pediatric retinal surgeon with great experience, trained at Little LV Prasad Eye Hospital, where she was working as a consultant as well, and she's one of the best in pediatric retina, and such a piece for us once she has joined our institute. Over to you, Divya.
Thank you, Dr. Meena, for that introduction, and thanks KSOS for giving us this opportunity. So I'll be talking about, because ectopia lenses always you will think in terms of only lens. So we need to look something beyond that. So that is why I thought like the genetics and the systemic thing is also very important in these patients. And ectopia lenses, when we think in some conditions, the lens is of normal depth, and it is subluxated or dislocated depending upon the extent of the zonules, which is weak. But one more thing which we need to look is the thickness of the lens and the whether it is a very small lens. So that is microspherophakia. So we need to differentiate these, and mainly we look at these because of the high refractive error, that is the high minus power which the patient might be having, or because of the astigmatism. And then the second thing would be the secondary glaucoma, or sometimes the retinal problems like retinal detachment. So as I mentioned, the normal lens subluxation and the microspherophakia, we need to differentiate when you see these kids. And the normal lens subluxation can happen in conditions like Marfan's, even homocystinuria, as Dr. Meena has already mentioned, and the complications which might occur because of the progressive subluxation. But in microspherophakia, we need to be very careful because the lens diameter as such is less, the thickness of the lens is more, and because of these, there is an increased chance that it can cause a recurrent pupillary block. So, and the refractive error these kids would be having would be on the higher side. So we need to initially differentiate between these two entities when you see these kids. And why genetic? She has already mentioned the systemic implications of these having ectopia lenses. So some of these are like associated with systemic, and some genetic mutations will have only isolated ocular pathology. So something like FBN1 mutation will be having usually associated with Marfan's, or sometimes rarely Weil's Marchesani, and isolated. And this one is the most common form of familial cases. So this is the importance of genetics, especially when you don't have a diagnosis. So ectopia lenses, you need to be differentiate whether it is a purely ocular or whether it is associated with systemic manifestations. So that is how you differentiate whether it is a syndromic or isolated. In syndromic, usually we come across is the commonest one is Marfan, but very careful when you have to diagnose something like a Weil Marchesani, because these are associated with microspherophakia and very high risk of pupillary block glaucoma. And another one is Cohen syndrome. So all these have systemic features. If you pick up the systemic features, it is very important to diagnose what could be the prognosis and what should be the follow-up of these kids. Very commonly come across is the Marfan's one, which everyone knows that because of the tall stature and the cardiovascular risk which is associated with this. Homocystinuria, you have to be very careful, especially when you take these kids for surgery under GA, because they have very high risk of thromboembolic episodes, so the hydration. The kids should not be overnight fasting or that thing we have to be very important keep in mind. The other causes would be ectopia lentis, pupillosticular syndrome, sulfite oxidase deficiency. So, and another one which, in fact, I had some patients who had operated earlier. Later, I came to know those who are at Trabossi syndrome. The important aspects of this is like a facial dysmorphism, lens subluxation, anterior segment abnormalities. And one more very important thing which I had seen in patients and which I did not know earlier was they would have something like a self-forming blebs. So we always ask the history whether there was a history of trap, but no, because their sclera is very thin, they spontaneously forms these bleb. So when you do such procedures in these eyes, you have to be very careful, especially when you plan for any scleral procedures, because the risk of thinning is there. And they have cardio and pulmonary complications. So very important is that first you ask a comprehensive family history when you see these kids, anyone in the family has been affected, then check it the systemic history, whether it has any cardiac issues, pulmonary issues, any skeletal issues regarding this, and then you need like a multidisciplinary approach to these kids, looking at the cardiologist, then pediatric ophthalmologist, orthopedician, etc. So now you understand that just a subluxation is not just subluxation, but it is a multi-system involvement, and you need that multidisciplinary care. So coming to the examination, a detailed functional testing, very important is that we need to see with this high power how much the kid is able to see. whether he is nearing or he is able to read near things, whether his life is getting disturbed because of this hyper what the kid is using. And then slit lamp examination, especially to look whether it is a microspherophakia or a normal thickness of the lens. And always, whenever possible, try to do a gonioscopy, because some of these kids might be having an basically abnormal angle pathology, or might be having, because of the repeated pupillary block, it might have caused an angle closure. So these things carry very important value when you plan for surgical management in this. And then screen for any of these, because in kids that gonioscopy would be difficult. So if any time you are taking the kid for a GA examination, then do for that. Then advise on family screening. So I mentioned the systemic complications. So the systemic investigations needed in these kids should pertain to all those system involvement. And genetic testing, as I mentioned, there are specific genes to pick up these mutations. And whenever you have a diagnostic dilemma, then go for a whole genome sequencing to pick up anything we are missing out on. So do we need a genetic testing in all these kids? As when you have an early onset, any family members are affected, and when there is any associated systemic features, or where you are confused whether the diagnosis is due to because of this entity. And also in following up these kids and family counseling. So these are the areas where you need genetic testing. And why it is important? Because you will know that inheritance pattern. It is very important in assessing the recurrence of this in the siblings or the newborn when they are planning the family, and the psychosocial support and the family screening. So how do you follow up and monitor this one? When you see these kids at the initial assessment, a baseline visual acuity, the lens position, intraocular pressure, and systemic screening. And you do it 3 to 6 months. If everything is stable for a period of 6 to 12 months, then you increase the frequency of, reduce the frequency of the follow-up. Every visit you have to track the progression of the lens subluxation, intraocular pressure measurement, and the refractive error which is happening. If it is progressing very fast, you need to see them every 1 to 3 months, and then you need to decide when you have to plan for the intervention. And including that, along with that, the systemic surveillance. So it just an ectopia lens, now it has opened up, like it is a diagnostic window where you get a chance. It is a very important clinical indicator of the underlying systemic genetic disorder, and early intervention actually would help us to provide an early better life for these kids, and also at tackling the systemic complications, and for genetic counseling also. So the integration of genetics with clinical ophthalmology transforms the congenital lens subluxation from an isolated ocular finding into a getaway for comprehensive life-saving patient care. Thank you.
Thank you, Divya, for that wonderful talk. How often do you send these patients for genetic screening?
See, in our scenario, the problem is that because it is little expensive, so many of them won't agree for that. But especially when you see the siblings or sometimes the very strong family history, then it is always better to send them. So sometimes you see the brother, sister are affected in the same family. When you ask the history, the father or mother also would have come affected with the same thing. So then it is better to have a genetic, especially in some syndromic, Trabosius syndrome and all those, and even Marfan's. Marfan's usually you will be able to pick it up because of the clinical feature itself, but other, it is very important.
Thank you, Divya.